Well, hello and welcome. On behalf of CME Outfitters, thank you for joining us today for this CMEO briefcase titled Tailoring irAE Care to Specific Patients. Today's program is supported by an independent educational grant from Merck Sharp and Dome Corporation, a subsidiary of Merck and Company, Inc. I am Dr. Ana Velázquez Mañana. I am an assistant professor in the Division of Hematology Oncology at the University of California, San Francisco and Zuckerberg San Francisco General Hospital. And I serve as assistant director of diversity, equity, inclusion, and accessibility of the UCSF Helen Diller Family Comprehensive Cancer Center in San Francisco, California. I'm very pleased to be joined today by Dr. Veronica Ajewole. Dr. Ajewole, can you please introduce yourself?
Thank you very much, Dr. Velasquez. My name is Veronica Ajewole. I am an associate professor of pharmacy practice at Texas Southern University. I am also a clinical specialist pharmacist in oncology, where I practice at Houston Methodist Hospital here in Houston, Texas. And I'm very pleased to be on this program with you today. Thank you.
Thank you. Here you start seeing our learning objective for today, which is to develop tactics for addressing healthcare disparities in patients who are experiencing irAEs. And perhaps we should start by even defining what an irAE is, which is an immune-related adverse events. So let's start by why would these happen and giving an overview of immunotherapy and immune checkpoint inhibitors. As many of you may know, immunotherapies really are drugs that we're starting to use more and more commonly in the oncology world. And what they are medications that leverage a patient's immune system to really allow or train our own bodies and immune system to go fight and identify cancer cells. So this is very different from chemotherapies as we think of them historically or classically, that are medications that directly are cytotoxic and do direct damage to cancer cells. In an immunotherapy, it's our own body and your T cells who are directly causing the immune system to get activated and do the killing of the cancer cells. These drugs are immunotherapies. There's many different types of what we would call an immunotherapy, like cellular therapies, CAR-Ts, and others. But the most commonly used throughout oncology are immune checkpoint inhibitors. So in general, sometimes when people will speak about immunotherapy, even though that term can be broader, they're referring to this immune checkpoint inhibitors who were first approved in 2011 for melanoma. And now we have over 10 different agents and others that are being developed that are approved and have expanding indications across many different cancer types, solid tumors, hematologic diseases, and that have moved from metastatic settings and second and third line treatments to now being used on first line therapy and being used also in patients who don't have advanced disease to try to cure patients. So you're going to see as pharmacists and clinicians that in all different practice settings, these are going to become a lot more common. As you'll see on that table, there are different types based on what the target is, whether it's anti-CTLA-4, PD-L1 and PD-1 are the most common that we see in general being used, and also anti-LAG-3. And as I mentioned earlier, there are others that are being developed and that we will see in the future, depending on what our clinical trials show us. Now, as these immune checkpoint inhibitors and immunotherapy agents have become more and more broadly used, we learn more about what the potential adverse effects or side effects are of these medications. If this is where, again, this subject or topic of an irAE comes in, which is, as I said, an immune-related adverse event. And when those happen, they're really our immune system attacking what would be otherwise healthy tissue. So instead of targeting or attacking our cancer cells, we may also have expression of the PD-L1 or CTLA-4 as targets of the immunotherapy in other areas in our body. And that can lead of our immune system becoming, as I like to tell my patients, in kind of overdrive, and may lead to then what we know of these as these immune-related adverse events. These are very common. More than 70% of patients who are in checkpoint inhibitors will develop an irAE, but they are very varied on how they may present and also on severity. So most patients may have mild pruritus from skin dryness or a mild rash, for example. And if that happens and you have a mild dermatitis, you may not need a treatment or need a topical treatment. But sometimes there can be really severe and life-threatening, like having, severe enterocolitis, in which patients may become extremely dehydrated and be admitted in shock into the hospital. Or I've had several cases of patients developing, life-threatening myocarditis or inflammation of the heart, or also, for example, as I treat lung cancer, pneumonitis or inflammations of the lung. And those can really lead to patients being admitted into the hospital and really, into intensive care units and needing multiple medications. So it's very important and key that we identify these irAEs quickly, so they can be graded and treated appropriately, and they don't progress into life-threatening conditions that can also be fatal. One important thing to take home as a message is that any patient who is in immunotherapy and has a new problem or a new symptom, we need to really focus or consider that this can be an immune-related adverse event. We're showing you here a graphic from a New England Journal of Medicine paper that really describes how irAEs can happen anywhere in the body, and also they can happen at different timelines. So it is very important for us to be able to identify those in patients very, very expeditiously. So, for example, patients may present with a headache or have new onset seizures if they're having inflammation or encephalitis on their brain. And as you'll see, all of this tend to finish in itis. So it is an inflammatory process of your own immune system attacking those areas of the body. These drugs, because what they do is train your immune system, are also very different from our common side effects that we see on other medicines. They may be long lasting and happen at very different timelines. Here, our half-life is less of a predictor of when some of these toxicities can happen. Veronica, I'm not sure if you want to add something else to particularly the timeliness of many of these irAEs.
It's very important, to make note of the timing of when these irAEs happen, because, clinically, we see patients ask us, okay, how quickly would they develop these side effects, right? And especially for patients that have been on traditional cytotoxic chemotherapy previously, or even if they've not been on traditional chemotherapy, they've had a friend, a cousin, family, or someone telling them, oh, you're going to lose your hair, you're going to vomit, you're going to do this. And now we are here giving them, immunotherapy agents, and we are going to discuss with them non-traditional toxicities, and also trying to manage their expectations around the timing of those side effects. So I really love this paper, and it's something that I always use, when it comes to discussing the timing of the occurrence and the extent of the occurrence of some of these toxicities with patients.
Thank you. And as we talk, it's not only important to be able to identify when these irAEs are occurring, but also to know exactly how to treat them. And one of the key things would be, one, of course, diagnosing it, but also thinking about what the treatments are needed for each. And primarily, the treatments for the immune adverse events are related to using corticosteroids, and that's something that we use as first line for most of them. And depending or not on whether patients respond to that, you may need other agents that would be immunosuppressive. So medications that commonly we would see used in rheumatology clinics are ones that we're using very commonly now to treat some of these adverse events who may be of higher grades. Again, thinking that our goal here is to be able to calm or shut down this overt immune response that the body is having that leads to the irAE. Now, there are a couple of them that are treated differently. So, of course, when we think about, for example, skin toxicity or eye toxicity, there may be the ability to deliver some medications topically. So if it is a very mild grade 1 rash, you may be able to get topical steroids instead of oral steroids. The other part that is important are those that are endocrine mediated. So many patients may experience, for example, hypothyroidism. More rarely, some people may develop new onset diabetes and requirement of new insulin. And this is really from our immune system infiltrating those endocrine organs or glands. And in many cases, these unfortunately lead to permanent damage of that gland. So on patients who may have either hyper or hypothyroidism from an irAE, compared to other treatments in which just doing immunosuppressive agents like steroids may be the treatment, patients require long-term hormone replacement therapies with levothyroxine and insulin if it was the pancreas that was affected. Besides the identification, the other important part is to think of the grading. And there are guidelines that exist from, cancer societies, national cancer societies that you can look up and read, which will show, depending on the specific type of irAE, what is considered a grade 1 and 2, which are usually milder and can be managed outpatient, versus what is considered grade 3 or 4, which in general need inpatient management. Important also to note that depending on what that grade is and what the specific irAE is, patients may be able or not to continue in this immune checkpoint inhibitors. So it really matters that we identify them early, that we diagnose the kind, that we're able to grade them appropriately to then determine the management. Now, as we had been talking, dermatologic irAEs are the most common, and there's a wide variation of what different skin irAEs can be seen with checkpoint inhibitors. On PD-1 and anti-PD-L1, this can occur in up to 40% of the patients, and with CTLA-4 inhibitors, those can be higher and up to 50%. When we see them combined, as you can imagine, then things become a lot more common. And many of these percentages, I would point out, also have been reported based on clinical trials. We have now evolving evidence of more real world data that may show us that this can be different or perhaps even more common. The most common thing we see that tends to be less severe is pruritus or itching, and it can happen also with a dermatitis or rash. We sometimes see also pigmentation of the skin or develop something that looks like vitiligo. And more severe things can be lichenoid reactions, bullous pemphigoid, which can be, present with bullae and tense vesicles on the skin. And those can be more severe and require patients to be admitted in the hospital. And very rare, but still quite severe, more common severe reactions like Stevens-Johnson's or TEN or DRESS syndromes, which many of you are aware because they're common rare severe reactions to many of our other drugs and require patients to get admitted severely ill to the hospital. So to try to frame this and bring this home, I think we're going to start by reviewing a case. And this, the case was of a patient named Sarah. Patient is a 42-year-old woman who has been diagnosed with advanced triple negative breast cancer. Her breast cancer was diagnosed after Sarah had multiple ER visits for pain in her breast. Sarah had immigrated from Sudan 4 years ago with her husband, and she has 3 children. She's primarily Sudanese Arabic speaking and has some limited spoken and written English comprehension. Currently, she's being treated for her advanced triple negative breast cancer with pembrolizumab, 400 milligrams every 6 weeks, and chemotherapy, cytotoxic chemotherapy with paclitaxel. And as you may remember from one of the earlier slides, pembrolizumab is an immune checkpoint inhibitor, and anti-PD-1, which we commonly see in clinical practice settings. So Sarah presents today to the emergency room with 2 months of pruritus and rash after starting her immunotherapy and chemotherapy. It is seen as having a macular pruritic rash. When she's evaluated, it involves her trunk and bilateral upper extremities. And I wonder, Veronica, is this something that you see commonly in your clinical practice of patients getting immunotherapy, and what other common complaints patients may present with when seeking care?
This type of presentation is quite typical, especially, in the Houston area where I practice, that is quite diverse when it comes to, the ethnicity and, seeing patients of diverse or a wide range of skin color, African-American, immigrants, Hispanic population, Caucasian. So, being able to clearly identify, what the patient is presenting with is very important. But definitely for patients on ICI, them coming in with pruritic rash that looks like this. It might be on the upper extremity, on the torso, on the back area, are some of the things that we see typically in the clinic.
Thank you. Definitely agree. And similarly in my practice. So before we move on, let's go to an audience response question. Which of the following can contribute to inequities in the management of irAEs in oncology care? So the correct answer here would be B, lack of access to interpretation services. Many of the other options are: one, ancestry and inherited genetic factors usually may affect how patients, for example, are able to metabolize a drug, or maybe more predisposed to certain side effects, but truly should not lead to what we call inequities or disparities on how somebody is managed a side effect. And similarly, patient misinterpretation of treatment instructions, puts blame on the patient rather than identifying what are some of the systemic problems that we see that lead to disparities in care.
As we move along, I would just like to talk briefly about the pathway, for irAE treatments and, reflecting back on the patient case that we just discussed. When you look at the patient Sarah, ideally, we would want Sarah to kind of move through the pathway where she recognizes the need for her to seek care, even though, looking at the background of the patient, it looks like she would rather go to an emergency room, right? She went to the emergency room 4 times before she was eventually diagnosed with the breast cancer, that she's currently being treated for. So her recognizing the need to seek care is something that is important. And then what is the capacity or ability for the patient to seek care? Right. So if she recognizes the need to seek care, the next thing is she actually able to seek care? We don't know what her family situation is. Does she have childcare responsibilities? What is her work schedule? What is it like? And, when she goes to emergency room is not necessarily a place to build that provider-patient relationship, right? That can lead to trust building and that can lead to, sustainable healthcare outcome. So those are some of the things that we need to consider. The other thing after Sarah seeks care, is now, can she actually receive an accurate diagnosis? So that's, a major predicting factor that will lead to the type of outcome that the patient would have after she actually goes through, the process of seeking care regarding the complaints that she has. After she receives accurate diagnosis, being prescribed the accurate treatment, does she have the ability to complete the treatment? It's another thing to prescribe a medication for a patient, is another thing for the patient to actually be able to complete the treatment. And of course, while the patient completes the care for the adverse events that she has, we still want Sarah to have the ability to continue treatment for a triple negative breast cancer. So we would not want a situation where the side effect from the irAE would limit our ability to complete treatments. I mean, if let's say she has a grade 4 type of adverse reaction where maybe a treatment plan needs to be changed completely, then okay, we would understand. But in this case, it's not bad enough to where we would not want her to complete her treatment. So the overall goal will be that we want Sarah to continue treatment and be able to complete the follow-up that is necessary for her to, be completely treated from the immune-related adverse reaction. And keeping in mind, right, that immune-related adverse events are quite time sensitive. So keeping that time sensitivity in mind, while she's going through this pathway, and also knowing that there are several barriers that can result in, delayed presentation as well as, delayed diagnosis when it comes to creating that pathway and successful treatment of patients with immune-related adverse events. For me as a pharmacist, most of us find ourselves in that pivotal role of educating our patients, as to the type of treatment they are receiving, toxicities that might happen from those treatments, and how to manage those toxicities. So a couple of questions to ask, when we look at Sarah's need to be able to recognize that, hey, I need to seek care, was adequate education on immune-related adverse events actually provided to the patient up front, right? When she was given the treatment plan, for a triple negative breast cancer consisting of pembrolizumab and paclitaxel, did our oncology team educate her adequately, on seeking care or how to recognize some of those immune-related adverse events. One of the other things too is now keeping in mind the background of the patient. She's an immigrant, she's non-English speaking. So the education that was provided, did it actually meet the language and health literacy need of the patient? And, that can kind of be a sensitive topic, for some people, because you don't want to act as if you don't understand what is being conveyed by your healthcare team. So sometimes patients will just, they can nod or, just kind of try to act as if they understand what is being communicated to them. But the onus is on us as healthcare providers to actually identify the need of the patient, have an understanding for their health literacy need, and be able to provide education for them at their own level. So language barrier cuts across, multiple, scenarios. But with that in mind, we know that language barrier can impact access to care. Because if we have a patient that has become uncomfortable maybe because of prior experience, or them feeling unworthy, or they don't want to feel embarrassed to say, hey, I don't speak English, or sorry, I don't understand, what you're trying to tell me, then that can limit their ability to seek care in the future. In the same manner, the ability for a patient to comfortably express themselves in English language or in any other language that they're comfortable with would impact the quality of care that they will receive, because there is always that subjective evaluation to say, okay, is this rash? Is it itching? Does it hurt? Have you tried anything to make it get better? But if a patient is not able to effectively communicate those things out to the healthcare provider, the quality of care that will be received can definitely be impacted. The same way the cost of care. when we have patients going in and out of the emergency room or of urgent care, for the same issue that could or might be addressed in a primary care situation, that definitely adds on to the cost of care. Language barrier ultimately also impacts patient-provider relationship. For us in the clinic, we're always seeking out opportunity to build a relationship with our patients, because we know that that goes a long way, not just for patients to know that we have their best interest at heart, not just for patients to know that the physician truly cares, but also to build the trust with the provider, and that the patient can actually be rest assured to say, hey, I'm going in to see my provider today, and I know my provider understands what I'm saying, and that they're actually willing to hear me out and build that relationship. Common causes of adverse events in non-English speaking population or patients that have English as a secondary language includes the use of ad hoc, personnel as interpreters. And I mean, this is something that happens very often. It happens quite often, in different clinic scenarios, to where, okay, you see a family member that is not trained, you see, a child, an uncle, or someone that is just a caregiver, or even sometimes we default to using a staff member that, okay, maybe they're Arabic speaking, or you have a learner that is Hispanic speaking, and you want to use that person as an interpreter instead of using a trained staff or a trained family to be able to get that, language barrier completely addressed. And also, for us as a healthcare provider, sometimes we find ourselves using basic language, just to kind of try to get by. For me, I am not Spanish speaking, so I cannot imagine myself trying to speak Spanish, if I'm trying to, communicate with the patient. I would, like, hey, I need an interpreter to be able to communicate effectively and efficiently with this patient. So trying to stay away from using basic language, watering down the content that we are trying to communicate over to the patient. And also provider being unaware or being, insensitive to the cultural beliefs of the patient population. So there are certain patients that have different belief system. Some patients are culturally, the cultural orientation is to have their skin covered, almost in its entirety. So having a dermatologic evaluation, for such patient could be uncomfortable, especially if there is a gender disconcordance, right? So some patients will not be comfortable showing their skin to, or certain areas of their body, to someone that is not of the same gender. We will talk a little bit about some of the recommendations, when it comes to addressing language differences, within the healthcare system, especially, reflecting on the barriers or the challenges that language differences can pose within the healthcare system. One of the things that we recommend, or that is recommended, is assessing the language preference and language assistance need of each patient. So more like during the onboarding process, onboarding a patient into the clinic setting, or, when you are, at the registration point, just assessing for, okay, what is their language preference and what is kind of their level of language comprehension, and if they would have any need for an assistance. And when it comes to utilization of language assistance services, keeping in mind that the acceptable form of language assistance services should be either bilingual staff or clinicians that have confirmed proficiency, meaning they've been trained, people that have been trained and that you are aware that, okay, they have the true capacity in a professional manner to be able to interpret, to the patient or to their caregivers, without, overemphasizing or underestimating the words or the verbiage. And that way you are not losing out on that ability to communicate and build a relationship with the patient. We should plan ahead of time right? Especially when we've done that assessment for the need for language interpretation and scheduled visit or calls around the time when interpreter service is available. And also providing written material in patient's preferred language. That's something that is key. Like, when you're talking, information can be missed, but when patients have something to take home, they can, open it up at their own convenience, read through, and always come back, to the clinic or reach out by phone or, however, communication dynamics to ask any follow-up questions. Anna, are these, some of the strategies that you see in your practice, or are there any additional strategies that you would like to share?
No, yes, definitely. I think that key is having trained interpreters that are, official, whether it's by phone or videos. We know that if you have an in-person or video, they tend to be a little bit more effective because it's more engaging than just a phone. Two things that I'll add that are important is one, when using an interpreter, we as the clinicians, the providers should be really talking at the patient, even if the patient is not understanding your language. It's not that I will be having a discussion with the phone or with the tablet and the interpreter then talks to the patient. You want to maintain that empathy. So an effective way to use interpreters is that you should continue speaking or focus towards the patient. And the other thing that I'll mention is that we have to also acknowledge that there's a lot of variability on language. Not every person that speaks Spanish has the same background, or not every Chinese person is going to speak, just Cantonese or Mandarin. There's going to be a lot of different dialects, or even, for example, in Spanish, a lot of different use of words. So I am from Puerto Rico and I'm primarily Spanish speaking. Spanish is my primary language. But if I speak with somebody who is from Mexico, they're going to have a very different use of certain words that I would. So even though I can communicate very effectively with them, I do have to be cognizant that sometimes some of the words that I may use, they may not truly understand, or some of the words that they're saying may require clarification. And when we use interpreters, one of the ways that I do that to try to make sure that the one interpreter is relaying the correct information as I meant it, and that the patient is understanding, is doing that teach back or asking back the patient what they understood method. And that can be really, helpful in making sure that we're translating correctly or interpreting correctly, and that your patient is also understanding and provides them the comfort or the option to ask questions.
Absolutely. Thank you very much, Anna. I mean, you definitely mentioned a great point there, because I find myself, kind of caught up in that, where I'm engaging with the interpreter instead of engaging with the patient, because then you lose that opportunity to build that relationship. So making eye contact and still being able to read the body language, because the patient is reading your body language the same way that you are reading their body language, and not just having a focused discussion with the interpreter, is something that, we continue to adapt when we are, in the situation of bridging the gap of, language barrier with the assistance of interpretation service. In addition to, the things we said, other things that can also be implemented as strategies to address health literacy level is, again, recognizing their literacy level early in relationship building, so that way we can avoid communication challenges and unintentional poor adherence, and not just adherence to the medication as it were, but also, even coming back to visits, right? There are times where patients are like, oh no, I just don't want to attend, I don't want to skip, I'm going to skip my physician visit, because they don't feel like they have that rapport that is being built with their physician, right? So recognizing the literacy level early and being very intentional in bridging that gap would assist in building a good relationship and promoting adherence for the patient. And like Anna rightly said, the teach back method, just to confirm understanding of the information is very, very key. In my practice, for example, with oral oncolytics, you sometimes you tell patients, okay, they are supposed to take 2 tablets once a day. And when they are doing the teach back, they could tell you, oh, I take 1 tablet twice a day. But 8 milligrams still goes into the body, but the time that it goes in matters. It's supposed to be 2 tablets taken together once a day. So the teach back method is a great way to always implement, to make sure that you're confirming that the patient understands, the information that is being shared. So looking back again at the patient case, of Sarah and, that individualized pathway, we're going to look, to see what are Sarah's options for the healthcare system. Are they limited because of lack of translator, either via phone or telemedicine? And also considering, asking the question, what might Sarah have to arrange in order to attend an appointment, right? Does she need transportation? Does she need to figure out care or provide child care for her family, keeping in mind that she immigrated from Sudan with, young children. So keeping that in mind. And also, do we need to consider, having a caregiver or family member accompanying her to the appointment? And what would that mean in terms of cost, right? If she's a primary caregiver for our children, if she's coming into the clinic, someone else would have to watch the children, and that is going to add some, dollars, when it comes to cost implication for Sarah to be able to seek care. So just, thinking about that dynamics and how that can impact Sarah's ability to seek care. Anna, is that something that you've seen in your practice, or do you want to shed a little bit more light on this?
Yeah, definitely. I mean, I see quite commonly that patients either need to work or don't have childcare as barriers to coming and seeking care. I think one of the other big problems we have to think about is also the cost of even coming to a clinic. So, paying for parking, paying for transportation, or limited access. If you have to take 2 buses to go somewhere that you could go 15 minutes driving, but you don't own a car, then that really makes it hard for patients. I think when we talk about now healthcare in the post-COVID era, there is a and that we're using, and patient portals and telephone calls and videos. And we always have to think that those also may be limiting for people who have low resources or people who don't speak English or live in areas that don't have broadband. So those are some of the things that I see commonly in practice that may affect how people like Sarah are able to receive care. Now, it's not just about being able to receive care, but also what are barriers that occur in the healthcare team side that may lead to patients like Sarah to not receive an accurate diagnosis. So when we think about what are some of the barriers that somebody like Sarah, who's coming in with a rash or skin condition that potentially is from an irAE, may face, we have to think of whether Sarah's care team members even can recognize dermatologic conditions in patients who have skin of color. This is quite important because, as we know, a lot of medical education and the books have been written using patients who are primarily light skinned or who identify as white. So therefore, rashes may not seem the same or may not look exactly the same, or people may not be able to recognize them on skins of different colors and backgrounds if they're not being exposed to that in their training. The other part is what really are resources that are available to help communicate to Sarah with the healthcare team members. And this goes back to what Veronica was mentioning of, do we have educational materials that exist in different languages, and do also our team members have the knowledge and are familiar with what specifically are potentially irAEs and side effects of these checkpoint inhibitors. So if I work in a large academic center, it's very likely that my emergency room physicians and nurses and practitioners and pharmacists are very aware. But if I'm on a primary care clinic in a rural setting in which it's very small and there's one doctor and a team of three, then it's less likely that they're going to be as aware or readily identify a rash on somebody who is on immunotherapy. So seeking this kind of educational opportunities like the one we're doing today is really important for this. Medical training in general has traditionally focused, and we know, on studying primarily white populations and European populations. And we see this across, genetic testing, the different groups that exist for even for cancer, for knowing what the genetic molecular drivers are. But in dermatology, it's really important. And when we talk about skin toxicities like Sarah has, we know that dermatology training has traditionally focused on diagnosing and recognizing conditions in people who have light skin phototypes. So, you can see here there's been a review that was done looking at dermatology books and training materials that have been used over time. And most of them included images that were on patients who were light skin, and less than 20% have included images of diverse patients of different skin colors. So if we're not even training the clinicians to begin with on recognizing conditions in patients who have skin of color, then of course they're more likely to misdiagnose or miss conditions. So we really need to be aware of this potential, this bias that exists in education, and make sure that we are evaluating all patients and updating all of those educational materials as time goes on. Another problem with underrepresentation that exists in dermatology is, as I said, that this really leads to delays in the recognizing and diagnosis of patients of all dermatologic conditions, but to oncology, very relevant to irAEs, particularly because diagnostics in dermatology require visual pattern recognition and recognizing that there may be similarities between different cases. So we want to make sure that patients, that not only are patients, as we talked before, are able to communicate their symptoms accurately with the teams, but also that the teams are able to visually examine and make assessments and think about the side effects that patients are having adequately. Now, here's some different examples. Dermatologic conditions, particularly related to drug reactions, can look like on patients of different skins of color. And as you can see, for example, a drug exanthem can look very different on a patient who has lighter skin versus darker skin, because you may not be able to readily or easily see the erythema or the redness that commonly is the main descriptive factor. But on deeper examination and on making sure that patients are on physical exam and touching the skin and being able to look at what the patient is complaining and reporting and getting an accurate history, people are really able to identify those and make accurate diagnosis. Now, besides making sure that our medical education is up to par with the diversity of our patients that we see and that make up our nation, we also have to think about what are other barriers that patients face to seeking care, to completing treatment. And the same barriers that patients face initially when you're trying to seek care, they still will happen when they're trying to complete their treatment. So for example, a patient who may have a skin reaction or a skin irAE may not be able to seek their oncology team. They may need to go to an urgent care or an ED, and in that place, depending on staffing or, as I said, the familiarity with these diseases, they may not be able to diagnose them accurately, and they may give a dermatology referral. And if your insurance doesn't cover a dermatologist, or if the wait for a dermatologist is 6 months, then this irAE is going to get worse. So we have to really think of, as we are designing treatment plans for patients and giving recommendations and talking with them, what are potential barriers to coming back for evaluation of symptoms? How can we prevent some of those barriers? Barriers that may exist to filling prescriptions, to getting their medications. for patients communicating with us and getting into clinics, and whether or not there are other referrals that are needed, and how can we make those timely for patients so their care doesn't get compromised.
Yeah, thank you very much, Anna. In addition to the barriers, that you've mentioned, other things to think about, are like interpersonal barriers. Is the patient able to make appointments at times that is convenient for them? And time that is convenient for the patient might not be the time that the clinic is open because of childcare responsibility, the type of jobs that the patient has. They are not able to take a PTO. They need to, be paid because they have, financial responsibilities to take care of their family. And also, maximizing services at each visit. So, whenever we have patients coming in, do we want to schedule labs and imaging and, other things around the total care of the patient around the same time, so that we don't have patients, coming in, quite often, because that would mean a lot. Everything kind of adds up, and can pose or become a barrier to optimal care for these patients. Other things to think about is transportation. Where I practice, we are in the Texas Medical Center, and traffic is not fun. Valet parking, the cost, and even the distance, right, from where patients live to where the clinic is at can be a barrier. And even for those that are practicing in a rural setting, or those that are living in a rural area, accessing care, if they need like a specialty referral, for example, they have to come out from their rural area to a specialized dermatologist for care, and that can definitely impose a barrier to care for patients. And whenever it's appropriate, the ability to arrange for a virtual visit or phone visit whenever it's possible, can at least assist in addressing some of issues related to transportation. Finances is also another, barrier when it comes to access to patient care for several patients. Knowing that the cost of treatment can be very high, even if the insurance covers it, insurance coverage is not always equivalent to affordability. So the fact that the drug is covered does not mean that the patient can actually afford the cost of the drug. At this time, we're going to ask one audience question regarding the same patient, Sarah, that we've been talking about. So Sarah is seen at the emergency department, and she's been prescribed prednisone for the treatment of her rash. Which of the following is the best option for ensuring that Sarah starts prednisone for the treatment of dermatitis? The correct answer to this question, especially if it's asking about, access for the medication, is option A. For us as a provider to ask the patient if she has a plan on how to obtain a prescription, and does she even have the finances to cover, the costs that prescription is going to cost? Does she have transportation to cover it? And does she have a pharmacy within a local area that will be able to fill that prescription for her? Anna, do you have any other thing, to add, when it comes to identifying and addressing barriers to treatment in this scenario?
No, I mean, I agree. I think that asking patients is always the number one thing. There may be very different reasons. They have a preferred pharmacy. There's a pharmacy that is across the street from them. There's a pharmacy that provides labels in their language. So they may really be prone to going there versus another one. And when asking also will bring up issues related to financial toxicity or challenges that the patient may have. So of course, we are always here trying to promote the discussion and identification of barriers early on. Another important part of making sure that we're able to individualize and successfully care for adverse events that occur related to checkpoint inhibitors is to make sure that our patients understand their follow-up instructions. And particularly, we just say, you're going to follow up with your doctor. That doesn't really work, because what does that mean? So we need to make sure that patients are given information about what does their cancer treatment and treat plan look like, what therapies are they going to receive? Are they getting this with radiation? Are they getting only cytotoxic chemotherapy? Are they getting immunotherapy or not? For how long? What are some of the red flags that you should be looking for, or common adverse events and things that should trigger a call and should trigger contacting your oncology team, or should trigger going to the emergency room because it is an oncologic emergency. So outlining those things and communicating them clearly, and what are the best ways to communicate with the teams, is really important. So for example, something I do is I give patients what are common red flags that they need to go to the emergency room for. These are things you need to call me for that are semi-urgent. What are the ways in which we're going to communicate effectively? You call for these. If you're able to use my chart or the internet, those are Monday through Friday business hours ways to communicate. For emergencies, pick up the phone. So these are common ways for us to be able to really outline for patients what they should expect and how they should communicate with us.
Yeah, thank you very much, Anna, for walking us through, pretty much, walking us through that individualized pathway when it comes to treatment of immune-related adverse effects for patients on immunotherapy agents. And I'm just going to talk briefly on some of the opportunities that we have as pharmacists, in personalizing immune-related adverse event treatment for patients. Some of the things that we do as pharmacists is medication evaluation. We do that on a day-to-day. So when we see patients presenting with a medical history of being on an immunotherapy, we definitely want to evaluate for what is the medication, how long have they been on the medication, and the chart that we showed earlier, that showed the timeline to some of these irAE showing up can kind of be a guide to say, okay, this is possibly what's happening to this patient, and being able to at least help us arrive at a appropriate diagnosis alongside all the entire patient care team. In addition to that, once we arrive at a diagnosis, alongside the physician and depending on the practice setting, now planning the treatment for the patients, considering what are the barriers, what are some of those challenges that the patient might have that might limit their ability to obtain the best possible treatment versus actual. Can the patient actually receive the treatment that they have been prescribed? And also considering the opportunity to individualize patient education, right? There are times where we want to educate patients in their primary language, obtaining, services of a trained interpreter, or we want to print and, send, written documents out for patients, and also identifying and addressing drug-drug interactions, because most often we make interventions that require an additional drug therapy to the patient's regimen. So we want to identify the interaction and also address those interactions up front. Other opportunities to personalize care for the patient, like we said earlier, using language interpreter, educating the patient about the side effects and how to manage those side effects, because when the patient is adequately educated, it's easier for them to remain compliant. It's easier for us to build trust within the community of patients and provide that patient-related trust, and also being proactive in recommending the next steps, right? Dr. Anna said it earlier, about you just telling the patient to follow up is not enough for every patient. So proactively knowing what the possible next steps are and sharing those information with the patients.
Thank you so much, Veronica, for that. Lastly, we'll leave you here with a list of potential resources when thinking about caring for patients from diverse backgrounds who may have skin of color, and particularly looking at those, dermatologic toxicities and diseases and how to be able to recognize them. I think, we've learned a lot today. So we're going to review now as we wrap up our SMART goals for this activity. As we had said, the first was to recognize barriers to healthcare access that may result in delayed presentations of patients who have immune adverse events. So thinking again about healthcare access, about how we communicate with patients, about financial, social, and other barriers that may affect them. We want to seek and find additional resources that can improve recognition of dermatologic conditions, and particularly irAEs on diverse patients or patients who are on checkpoint inhibitors and who have cancer, is to really plan ahead and try to plan ahead that cancer treatment plan that is going to be multidisciplinary, and think about how do we facilitate that financial barriers or transportation barriers or language, health literacy do not affect the quality of health that our patients are receiving. So to finalize, we want to make sure that you're able to check out the other cases in our pharmacist irAE education series that are listed here. Also, these activities, as well as many other educational resources for clinicians and patients, can be found online at the CME Outfitters Oncology and Virtual Education Hubs. And the links are provided for you, and you'll find many education resources for clinicians and patients on these. To receive credit for continuing education after completing today's activity, please make sure that you are completing the post-test and evaluation online. We want to thank you all for participating and providing the best care for your patients. And I want to thank Veronica really for joining us today on this discussion. So thank you all and take care.
Thank you very much, Anna. I really enjoyed the discussion, and thank you for having me.